For question 9, if you said B, vaccinated against hepatitis B, you are correct. She only has a positive Hep B surface antibody, which is consistent with vaccination. Additionally, since she's vaccinated with documented immunity, she needs no revaccination or post-exposure prophylaxis for hepatitis B after her exposure. For question 10, A, recover from hepatitis B, is correct, as the patient has both positive Hep B core antibody and a positive Hep B surface antibody. For question D, window period before recovery is correct. Question 12 takes us to a new topic. In this case, B, IV hydration and nausea control are correct. This patient most likely has acute alcoholic hepatitis, but his Maddrey discriminant function score is less than 32, indicating that steroids are not indicated in this case. He also has no signs or symptoms of withdrawal at this point. He does not need to start therapy for alcohol withdrawal with benzodiazepines. Alcoholic liver disease occurs on a spectrum of severity and typically occurs with daily heavy alcohol consumption, defined as more than 3 standard drinks per day for a woman or more than 4 standard drinks per day for a man. Alcoholic steatosis is a common chronic condition and is usually asymptomatic, but you may see elevations of AST and ALT, typically in a 2-to-1 ratio, as well as hepatic steatosis on ultrasound. This is reversible with alcohol abstention. Acute alcoholic hepatitis is an acute condition that typically occurs in patients who have a history of heavy alcohol consumption as well, but can be triggered by a sudden increase in consumption. These patients are symptomatic and will have jaundice, fever, anorexia, and tender hepatomegaly. The AST and ALT will be very elevated, also usually in a ratio of 2-to-1, in addition to elevated bilirubin, prolonged PT, and leukocytosis. Diagnoses can be made clinically, but if biopsy is done, then ballooned hepatocytes and an inflammatory infiltrate with neutrophils will be seen. The Maddrey discriminant function score, or MELD score, can be used to determine if a patient may benefit from systemic steroids, but otherwise treatment is supportive. In severe cases, urgent transplantation can be considered, especially if they are unresponsive to steroids and progressing to fulminant liver failure. Alcoholic cirrhosis is chronic and occurs as a result of years of inflammation and fibrosis due to alcohol consumption. It is not fully reversible, but alcohol cessation can help slow progression and reduce the risk of decompensation. The only cure is liver transplantation. Metabolic-associated steatotic liver disease is now one of the most common causes of cirrhosis in the U.S. The spectrum of this disorder can range from benign steatosis or fatty liver disease to metabolic-associated steatohepatitis or MASH, to cirrhosis and the development of hepatocellular carcinoma. Hepatocellular carcinoma doesn't require cirrhosis to develop, but can develop earlier in the course of the disease. The risk factors for MASH include female gender, age over 45 years, BMI greater than 30, an AST to ALT ratio greater than 1, and type 2 diabetes, or other manifestations of metabolic syndrome. Patients may be asymptomatic, but when they do present with symptoms, they may have fatigue, malaise, right upper quadrant fullness, or right upper quadrant pain. On exam, they may have evidence of hepatomegaly or stigmata of chronic. The management of MASLD and MASH is closely tied to the management of metabolic syndrome. Patients are encouraged to lose weight in a healthy, gradual way, to manage their diabetes and other manifestations of metabolic syndrome, and to minimize other hepatotoxic agents like some medications and alcohol. GLP-1 medications are currently under investigation for the management of MASLD and MASH. In 2024, resmetirom, the first drug approved specifically for MASLD, was approved. Let's move on to a new topic.